All right, let's make a start. I don't see anyone else coming in, so that's fine. So let's make a start. So, firstly, good morning, everyone. Hope everyone's doing well. We are basically going to run through the screening of a hospital drug chart. Um, this can be useful for obviously when you're on the wards or if you are going for an interview, especially if you're in community where you might not have seen a sort of drug chart and it might be a different way of working. So hopefully this is a refresher from your uni experiences, but also solidifying. There's another person coming in. Just also solidifying any doubts or knowledge that you're unaware of. So we'll go through that in a second. So first off, just a little caveat to this is that it's a generalized overview. So I will be talking through the steps and thought process to ensure you've covered all the aspects when you're screening the drug chart. However, the step-by-step thing might be different because all drug charts are different, they're not the same, and obviously a lot of places have gone electronic. So the hospital I work at currently is all electronic prescribing, so everything's in one place, which is really convenient. But obviously my steps and things might be different if you had a paper drug chart in front of you and you're going through that. Cool. Okay, so with that said, when a patient is in front of you, so when you first get them, they're admitted to you. Let's take off this bit of my screen here. Yeah, when they first get admitted, obviously they get their level 1 medicines reconciliation done, and the nurses, doctors, and all that going through their notes. So the first point when I would screen the drug chart is to look at the notes, see why they're in, what issues they have, what past medical history, social, smoking history, and what their plan of the admission is. Obviously, they're in an acute setting, so we want to keep them in that acute setting for as short as possible, and get them back out safely. So with that, these like the notes could be electronic or they could be at the end of the patient's bed, etc. That will go from hospital to hospital and vary. Also, a key thing to look at is observations, bloods, lab results. This will obviously drive renal function, if they're liver, if they've got any liver issues. Just give you a good background of the patient, and then things to ensure you've checked when you're going through the patient. So, are they able to swallow? Will they be in any pain? Will they be sedated? Most people will, or every adult patient needs to have thromboprophylaxis scoring done, and then if they need it, we'll come on to that in a second. If they're either sedated or in some elderly patients, they might have a bit of delirium. So is this going to be treated? It's going to be monitored. Also prophylaxis, glucose control. Obviously, patients that are diabetic and under stress, their glucose control can go out of sync, especially with the change in diet as well. This can also happen with patients that are non-diabetic or undiagnosed diabetes. So glucose control is always one to monitor. Make sure med effect's been done, which I'll come on to in a bit. Antibiotics, so making sure that they're on the right antibiotic at the right time, doses and durations are appropriate for them, making sure every medicine's that's on the drug chart is accounted for, why they're on it, should they be on it. If they're not, then you should deprescribe. Electrolytes, obviously, this kind of monitoring of the drug effects and also the clinical state of that patient, and obviously checking there's no interactions, etc., etc. So we'll just go into this. So that's the overview of the patient. That's the things that are going through my mind when I'm going through the patients when I'm screening them. One bit here, so additional information section. So checking their smoking status, that's sometimes missed. If they are a smoker, they're in an acute hospital, will they need nicotine replacement? And you can go through the 3 steps of smoking cessation with them, which kind of bases off the community model. How do they have their medicines? So if they're in a DOSIT box or a medicines compliance aid, that will obviously change how much knowledge they know or don't know around their medicines. If they're in a care home, is it the nurses that administer them for them? Allergies and their reaction, that's obviously a big one. So we don't want them to be on any allergies that we don't want to be on any medicines that cause an allergic reaction. And obviously knowing what the reaction is allows us to manage that. So if it's a mild rash or might be something is obviously a lot different to anaphylaxis. Their age, their weight, their height, just understanding what the patient currently is, whether their weight and their height, their BMI, that can change their drug handling with hydrophilic and lipophilic medicines, and also the patient themselves. If you're able to speak to them, checking their adherence, checking if any OTC meds, any herbal medicines, and how they are actually getting on with the medicines, because they might have come in for a reason where they're not taking their medicines. So that will obviously affect that. And then moving on, so the patients, we've touched on this already, but the patients, how we get the medicines into the patient. So can they swallow? Are they on IV medicines? What access do they have that we can get the medicines in? And then thinking about this is pulled from one of the drug charts in my hospital. Think about the conversions. Not every medicine is bioavailable the same as oral to IV. Obviously, IV being 100% bioavailable. And just knowing those. So if you are switching a medicine that's normally oral to an IV, then making sure you're converting it correctly. So that's a good thing when we're looking at this patient, is how are we going to get the medicines into them. Next one. So VT prophylaxis. We've already spoken about this briefly, but basically it's everyone should be assessed, and it's basically bleeding, or so risk of clotting versus risk of bleeding. And here's a snapshot of a drug chart with a thromboprophylactic section of it. So normally it's a low molecular weight heparin, so enoxaparin, tinzaparin, dalteparin, and these are based on weight and creatinine clearance. So with this, these are all scored up. So obviously the more clotting ones you have, the more indication there is for VT prophylaxis. But obviously if they're a young, healthy, they're moving around, they might not need any VT prophylaxis, but make sure the scoring has been done. That is a national guidance thing. So make sure that's done. It's appropriate based on their weight and renal function. So then the antibiotic section. So see the antibiotic section is usually a section aside from the regular medicines or PRI medicines or infusion medicines, allows you to look at their antibiotic history along with what they're currently on. So a key thing with this is the allergies. Always make sure the allergies, obviously penicillin being a buzzword, and in an interview and obviously in real life, sometimes the cephalosporins and that are missed off. So just making sure you're aware of those, checking the indication, checking the dose is appropriate. So treatment versus prophylaxis versus the renal function, duration of therapy, and stepping down. So if they're on IV, when they're going to step down to oral, when they're going to be reviewed, making sure that you're monitoring the lab results such as the CRP and the white blood cells, etc., to make sure that they're getting better. Top tips. So not every microguide is the same. So local guidance drives antibiotics. So checking which demographic you're in, what's first line, what's second line, when to step down. Also, if they've had an extensive antibiotic history, then that will change what they start with. They might have cultures been done, so they might already know resistance, or they're treating empirically. So that would also drive which has been selected. And at the bottom, I've just included a little antibiotic section of a drug chart. So what the indication is it prophylactic? Is it empirical? Is it definitive? So definitive being they've done cultures, what they're starting, when they're starting it, when they're stopping it, frequency, etc. Just omit another person. And then each day, what time they're giving it, the date they're giving it, and then these bits here are reviews. So making sure they're having periodic reviews to make sure that the antibiotic is working and it is the most optimized for that. You might have had cultures come back. The next point is variable dose medicines. So these medicines are medicines that are regular, but the dose that is given might change. So a key one here is warfarin, lithium, where you're basically monitoring the drug level to then dose the medicine differently each day. So you might do 5-5-10 of warfarin, or 5-5-5 even, and then monitor and then you can adjust from there according to the ONR result. So these ones, that's why you leave these, and then the drug level at the top, and then the time taken, and going through that then. So just checking that these are done and they're not being prescribed on the regular side is a key thing, because someone's stuck on a warfarin dose that might be wrong, or they might need to monitor, is obviously can be a big issue. So yeah, so these are ones that usually require drug monitoring and adjustments to ensure the therapy is correct. So the next point, I've gone in the insulin section. So like I said, most places do have an insulin side of a drug chart. These are variable, and they can be very variable in hospital, especially if a patient's come in with BMs that are off already. And also being in hospital, being in an acute setting, being acutely unwell sets off stress response. So you do get erratic BMs alongside maybe the change in diet, or them not being able to manage their insulin as well as they normally do. A key thing with this is making sure that the units used and that is prescribed correctly. Most of these charts have it already inputted, so you just put in the number to reduce that risk. But if they are prescribing, make sure the units is written out in full and not IU, because that can be sometimes mistaken for letters, or numbers, even 1 and 0. And yeah, again, this is Jen checking the blood glucose alongside this to make sure they're in range. Then you got the PRN section. So, missed that section here. You've got the stat and infusion chart section. So stat obviously being one-off doses, and then the infusion charts. So the stat stuff might be for treatment. So it might be zoledronic acid, or it might be adrenaline down here as shown, or it might be one in relation to a hydrocortisone if they just want one dose of it to reduce the inflammation. Second to this is obviously the infusion stuff. So this is infusions that are made up to given over a longer period of time. These can be stat infusions, but they're usually on a different section of the chart. When you're screening these, it's making sure that obviously the dose is correct for the patient, additional to how fast they're given it. Is it in the right fluid? Is the right concentration? And obviously compatibilities, both if you're making a medicine up in the same bag, but also if you've got if you've only got one entry point, so you've got one lumen to go down, there might be multiple drugs going down it. Are they able to be given at the same time? What period of time do you have to give in the different, if you're given different drugs? So yeah, and also if you've got a Y site, the medicines will meet in the middle. There also can be incompatibilities there. So a good reference also for this one would be Medusa, or any local practice guidance in hospitals. But Medusa is a national one, which most hospitals do use. Cool, and making sure that's prescribed all right, and the rates and everything's fine. Good. Next point, PRN medicines. So medicines that are given when required. So typically pain, constipation, diarrhea, sedatives, etc. A key point with this is that these obviously are alongside regular medicines. So sometimes you might see they're on cocodamol on the regular side, but then someone puts paracetamol on it. Obviously, if they take them both at the same time, you could get overdosing. And also checking the dosing frequency. So if it's one tablet every 2 hours, but you can only have 8 tablets in a day, then there needs to be max 8 tablets written on that. So making sure that these PRN medicines are still within the total daily dosing, additional to regular, and also if PRN is given hourly, you might be overdosing in that sense. But it's good to account for all of these as well when you're looking at your patient, and if they're using a PRN medicine a lot, it might be reason to put it on the regular side and review at a later date. Good. And then finally, just put this one in because obviously oxygen therapy in recent months recent weeks, actually, months, has been a lot higher. And it's making sure that oxygen is a drug. We do treat it as a drug. It is a medicinal product. So when it's being prescribed, so I've just included a little oxygen prescription bit here, but when it's being prescribed, it's knowing what the target is. The lower targets are usually used for people that are at risk of CO2 retention. So those are the ones that are smokers, COPD, elderly, what other reasons are there? But yeah, just making sure that the target's written on there. Also how it's going to be delivered. So is it going to be a nasal cannula? Nasal cannula. It's going to be a face mask. It's going to be a venturi mask. Is it going to be a bag, a reservoir bag? All of these are different. So obviously the nasal cannula is for lower rate oxygen therapy, where the reservoir bag is for high flow, up to 35 liters, I believe, therapy. And making sure this all been prescribed so making sure it's specific of what they're prescribing. All the sections have been filled out. Obviously, this is a section that's not filled out properly. And also, if the patient is on oxygen, make sure it has been prescribed. You can see the patient if they've got an oxygen running. Make sure it's been prescribed. The only time it shouldn't, or it doesn't have to be prescribed, obviously in an emergency, you should be able to give oxygen in an emergency setting without a prescription, but it should be prescribed when convenient. And finally, if you are giving the oxygen via cylinders, make sure they're being stored correctly. There's been a lot of issues where they've been put in the bed and the patient, and they then have a malfunction in the patient's bed, and obviously that's not a good thing. Also, if the patient is a smoker, like we said, with smokers and COPDs might be on a reduced oxygen target, but they might be smoking. I've definitely seen people and stopped people trying to walk out with their cylinders to go for a cigarette. Oxygen is very flammable. So just some things to note on that. Also, if they're on really high dose oxygen, their levels aren't maintaining above 90%, that's a medical emergency. So if they're more than, I think it's less than 90% on more than 35 litres, 35% of oxygen, that is when we would call the emergency team to make sure. Also, another point on this is that making sure that when things are driven by oxygen, so nebulizers, make sure that's accounted for in the oxygen intake. So some drugs are driven by oxygen, others are driven by air, just making sure that's the case. Also, if you're in a hospital setting and you're using the outlets on the wall, you can see how much and how you can use the gauges to see how much has been delivered. Does that match the prescription? So it's that double check of what's actually being given is correct. Okay, so that's my very, very quick run through of how you would screen a drug chart and all the different aspects of it. So if we go back to the very start, so in all of this, it's making sure that we are understanding what access the patient has, what their current position is in terms of their renal and liver function, and their drug handling, making sure that if they come in with a broken leg, they're probably going to need analgesia. If they're not going to be very mobile, they're probably going to need prophylaxis. If they're on medicines that irritate the stomach, they're probably going to need ulcer prevention. If they've got diabetes, then obviously glucose control is a big one, but also everyone should be having their blood sugars monitored in hospital. If you haven't got diabetes, it might be less regular. Also, make sure that the medicines that they're on at home are all accounted for while in hospital. Some might not be needed. If they come in with diarrhea and they normally take Senna, obviously you wouldn't need that. Making sure the antibiotics, if they're on antibiotics, making sure that they're appropriate for the indication, appropriate to local guidelines, and also the durations and the reviews are all accounted for. Making sure that every medicine's on the drug chart is needed and it has a rationale for being there. If it doesn't, can we deprescribe? We don't want to have any patients that are having issues, side effects from their medicines simply because they're on too many, or we're trying to treat a side effect when we should just take out that medicine. General monitoring, so electrolytes, so some medicines obviously reduce sodium, some increase potassium, etc. So making sure we have a knowledge of what's going to be going up and down if we're starting a medicine, what we should be monitoring, and also other lab results. That's obviously the renal function, liver function, as that can affect drug handling. Again, interactions, allergies, duplication, side effects. These should be our bread and butter, just acknowledging that when we're starting something, what are they on? Will they interact? Will it increase one? Will it decrease the other, etc. And finally, stop dates. If they're on fluid offloading, making sure that the diuretic is got a stop date, antibiotics got a stop date, and monitoring all that. So that's basically a very quick, brief run through of everything I would go through on a drug chart. is there any questions that people want to go through? If you put them in the question box at the bottom, or if I just come off of this and we can have a chat. If anyone, does anyone have any questions on anything? Yeah, so what I'll do is I'll download these slides and I'll post them up so for you all to have. If you all just message me on the Instagram, I can do that. Also, I want to put this on a on YouTube so everyone can then review if you like. But does anyone have any questions regarding the presentation? Anything that I've gone through too fast, because we did go through it very quickly. If not, then you can feel free to message me on Instagram via the website. If there's anything else, no. Okay, that's fine. So what I'll say is just have a great rest of the day, and hope to see and hear from you soon. So just leave you with the final bit of, if you haven't already, give us a follow on the website and on the pharmacy page. Hopefully Instagram page that is. Hopefully you found this helpful. And like I said, send any questions or any other things you'd like me to go through via the website and or Instagram messaging service. Okay, thank you very much. Have a great day and see you soon.